Now this goes back to the 1980s and 1990s, where it was very commonplace for a woman to be prescribed hormone replacement therapies. So if you were going through menopause, take hormone replacement therapies. Irrespective of anything else, just take them, which obviously was not a good thing. That's where this study came from. So when they shut down the presses and said 25% increased risk in breast cancer, everybody freaked out, almost 80% drop overnight. Well, here's the part that's so deceiving. And here's the part that gets so frustrating. If you look at 4 women compared to 5 women, that is a 25% relative risk increase. If you look at the absolute risk, there was 1 additional woman per 1,000 that developed breast cancer. That is a 0.1% increased risk in breast cancer. Well, how about the arm that was without uterus that was able to be prescribed estrogen alone? Well, guess what? That group saw a 25% decreased risk in breast cancer. So when you look at this study, what all you hear is there was an increased risk in breast cancer. And anytime anybody said anything about the benefits of hormone replacement therapy, it's automatically drowned out by breast cancer. That's dangerous for lots of reasons. Number one, it's not accurate because the increased risk is very, very minimal, number one. Number two, the women in the study, the 27,000 women in the study, median age, 62 years old, well outside when a woman would normally start hormone replacement therapies, number one. Number two, they were taking synthetic hormones, conjugated equine estrogen and medroxyprogesterone acetate. We now today use what's called bioidentical hormones. Number three, about 30% of the women in the study had underlying comorbidities, obesity, diabetes, hypertensive, hypercholesteremia. These were all women that were, a significant portion of them were not healthy. So when you look at this study and you see they put out there that breast cancer, every time somebody tries to even give you any benefits to hormone replacement therapies, it's automatically drowned out by breast cancer. And that is dangerous. If there's no greater clue that everything was flawed about that, if there's no greater clue, it's that one of the main lead principal investigators in this study, her name is Dr. Joanne Manson. She was one of the lead principal investigators back in 2002. She now has come out on podcasts saying, hey, I was one of the lead principal investigators on the study. It is not fair the way the information was incorrectly extrapolated from the study. She has come out and said that. Now, again, I'm prefacing all this with, I'm not saying every single woman should do hormone replacement therapies. That's not what I'm saying. But what I am saying is women must be educated on it, because guess what? There's an extreme fear of breast cancer, and rightfully so. Breast cancer is disgusting. Breast cancer is horrible. Breast cancer makes me want to gouge my eyeballs out. I hate breast cancer, but let's be realistic. A woman is 8 to 10 times more likely to die of cardiovascular disease than they are breast cancer. So if hormone replacement therapies truly did increase your risk of breast cancer by this much, how about cardiovascular disease? This is what you're most likely to die from. Well, guess what one of the most protective hormones is for heart health? Estrogen. Guess which hormone you lose when you go through menopause? Estrogen. Danny and I, us two men, we make more estrogen than a postmenopausal woman. There's a reason why women have about a 10-year heart protection over men. So if you're a 40-year-old woman, you have the heart of a 30-year-old. That 10-year heart protection you have all the way up until about the age of 65. Now at 65, a woman becomes more susceptible to cardiovascular disease than men do. Why is that? Well, the thought process is 51's average age for menopause. When a woman goes through menopause, she loses estrogen, which now means she has those 14 years on average of no heart protection. Let's talk about osteoporosis, osteopenia. This is one of the most under-respected diseases, bone disease. You do not want to see the stats for hip replacement surgeries over the age of 65. The number is staggering. About 30% of people who have hip replacement surgeries over the age of 65 die within 1 year. Okay, I'm not saying any of this to be morbid. I'm not saying any of this to try to demotivate anybody. I'm just trying to help you to recognize how significant the role of estrogen is. Neurodegenerative disease, brain. 2/3 of Alzheimer's patients are women. Why is that? Right? Does anybody think about that? The thought process might be you have estrogen for your entire reproductive life cycle, date of first period to date of last period. Then all of a sudden you lose the estrogen. Is that what's the cause of dementia? That's hard to tell. There's a gene called an ApoE4 gene. 2/3 of Alzheimer's patients carry that gene. There's now some studies that show maybe estrogen provides protection against that. This is where it gets crazy, guys. This is where it gets nuts. And there's so many misconceptions, and there's just nowhere to go to get accurate information. The GYNs, unfortunately, and this is no offense to anyone who's medical, because I have every ounce of respect for every medical person. I don't care if you're a doctor, if you're a nurse, I don't care what you are. You enter that field because you want to help people, because you want to save lives. But let's be realistic. Our medical community, especially our doctors, they need a lot more training on menopause. This is something that gets totally shuffled underneath the rug. And again, I'm not bashing GYNs, but I get a significant number of phone calls from GYNs that call me a little bit upset because I was talking to their patient about hormones. 30 minutes after having a conversation, they're thanking me for educating them on hormones. It's dangerous. It's wild. It's scary. Couple definitions I want to hit on, you guys, because this is something I feel like, when I work with a lot of ladies, a lot of times there's all these misconceptions. Let's start with perimenopause. Okay, you might hear premenopause. Technically, we don't like to use premenopause. Perimenopause is more the accurate term. It's around the time of menopause. Average age for perimenopause, 43 years old. Okay, about 85% of perimenopausal women will exhibit the vasomotor symptoms, hot flashes, night sweats. And they can be pretty debilitating. I have to tell you, when the ladies come in and they sit down and they're talking to me and I ask them, I say, okay, hey, just real quick, are you experiencing any of the vasomotor symptoms, hot flashes or night sweats? If they start off with, I'm like, stop right there. You're not experiencing them. You're not experiencing them, because if you were experiencing them, you would get very upset with me. This minute I ask about hot flashes and night sweats, you say, yes, I am. Okay, a lot of ladies will experience that stuff. Here's the issue. 43 is average age. Those symptoms can last anywhere from 7 to 10 years. 51 years old is the average age for menopause. Menopause, the medical definition, is 12 consecutive months of no period. So if you look at menopause, it's technically diagnosed retrospectively, because after 12 months of no period, not 11 months, not 11 and a half months, not 10 months, 12 consecutive months, you're now considered to be menopausal. And then after that's considered to be postmenopausal. You lose that significant estrogen once you go through it. And there are multiple ways this can happen. I talk about medically induced menopause. You all might have heard, you know about hysterectomies, where you remove your uterus. There's also a procedure where you remove your uterus and both your ovaries. This is called a bilateral oophorectomy. When a woman loses both of her ovaries, almost overnight, you will get thrusted into menopause. And here's the issue. The longer a woman goes without hormones, the more dangerous it is for heart, bones, and brain. I'm going to give you a trick question. I don't want this to, again, I don't like any of this stuff to be morbid, but I really want to give you just the importance and the significance of cardiovascular health, mainly ASCVD. You might have heard of that, atherosclerosis cardiovascular disease. This is really one of the only inevitable diseases of our species. Almost every single living, breathing human will die with atherosclerosis, some form, not because of it, but with some form of it. I'm going to give you a trick question. Danny, you're probably the only one that's unmuted. I might have already asked you this question. If I did, just pretend like I never asked you for everybody else on here, okay? I'll ask you all a trick question. Patient presents with their first major cardiac event. So in the world of medicine, this is called a major adverse cardiac event, MACE. Patient presents with their first major cardiac event. Male, female, does not matter. What is the number one symptom they present with? Remember, this is a trick question. Don't give it too much thought. Danny, if I had to ask you, what would you say is the number one symptom they present with?
Say chest pain.
A lot of people say chest pain, right? Pain in the arm, shortness of breath. You ready for this one? Remember, guys, I told you the trick question. Sudden death. 49% of people who suffer their first major cardiac event die. Why do I bring that up? I bring that up because about 90% of cardiovascular risk is due to modifiable, preventable lifestyle issues. Number one, don't smoke. Number two, manage blood pressure. Number three, monitor your lipids. You do those three things, you will decrease your odds of dying by cardiovascular disease by about 90%. The problem is all emphasis is put on breast cancer. And again, I'm not taking anything away. Please remember that. Not taking anything away from that. But we have to pay much more attention to cardiovascular disease. Thyroid is another huge issue that I deal with all the time. Guess what? Guess out of men and women, guess who's more susceptible to thyroid issues? You guessed right, women. Hypothyroidism, right? This is underactive thyroid. This is another thing that gets totally misdiagnosed by doctors. They check what's called your TSH, thyroid stimulating hormone. They don't check what's called your T3. So TSH produces T4 thyroxine, that converts to T3. Well, guess what? If you have a normal TSH level, but it's not converting to T3, you now have issues, but the doctor only looks at TSH and says, you're totally fine, no problem. Or they put you on what's called a T4. Again, these are all things. You show me a menopausal woman, and I will show you a whole list of things that's going on. Belly fat. Okay, I can tell you almost every single woman who comes, again, in this menopausal phase, it's belly fat. All the weight redistributes to that middle region. The other thing I hear all the time from ladies, I'm doing the same thing I've always done. I'm eating the same way I've always eaten. And not only am I not getting better, am I not losing weight, I'm actually gaining weight or going the exact opposite way. I don't want to sound negative when I say this, but there's next to no way you can overcome a hormone imbalance. And I don't want to sound demotivated when I say that, but if you're fighting a hormone imbalance, you can exercise 8 hours a day, you can eat 200 calories, but guess what? Those hormones are going to override that. Those hormones are going to prevent you from that. The weight loss medications, let's talk about that for a second. This is all the buzz right now. A lot of women who come in initially thinking they want the weight loss medications, a lot of times what they really might need is the hormone replacement therapies. You guys have heard about Ozempic. I like to set the records a little bit straight on these weight loss medications because as ladies, and as guys too, but as ladies who are struggling, who are really trying hard to do what they have to do that just aren't seeing results, there's been a huge marketing campaign, a national marketing campaign pushing what's called GLPs. These are glucagon-like peptides. The most popular one everybody thinks is Ozempic. Ozempic is not a weight loss medication. Ozempic has an FDA indication for type 2 diabetics. It helps to lower A1C, hemoglobin A1C, which is an indicator of diabetes. If you have a 6.5 or above, you're considered to be diabetic. Ozempic was approved by FDA back in 2017 to help lower A1C. The active ingredient in Ozempic is what's called semaglutide. So fast forward to 2021, FDA fast-tracked approval for the weight loss version, which is called Wegovy. So if you look at Ozempic and you look at Wegovy, they're the same exact active ingredient, which is semaglutide. The difference is Ozempic has this much, Wegovy has this much. So to say someone's taking Ozempic for weight loss is technically not accurate. They're taking that for type 2 diabetes. Go forward even further. We now also have what's called tirzepatide. So where semaglutide is what's called a GLP, a glucagon-like peptide, tirzepatide is what's called a glucose-dependent, insulinotropic polypeptide. You're all going to be tested on this stuff. You didn't even know it. That's in conjunction with the GLP. You might have heard of Mounjaro. There's a lot of advertising going on for Mounjaro. Mounjaro also is not a weight loss medication. Mounjaro is a type 2 diabetes medication. The FDA just approved it for weight loss. The brand name of that's called Zepbound. So when you look at these weight loss medications, there are side effects that are tied to weight loss medications. Are they effective? Yes, they're extremely effective. They work really, really well. But the issue with these medications, and what you have to be cautious of, what's causing the weight loss, what's causing the inability to lose that weight might be hormone related. Let's talk about the different ways that hormones can be administered, because there's lots of misconceptions about that too. First off, if you are a woman that still has an intact uterus, you will never, ever, ever take estrogen alone. Estrogen alone, if you still have a uterus, can cause what's called endometrial hyperplasia. This is a thickening of the lining of the uterus. If you have a uterus, you would never take estrogen without taking progesterone. We have pills, creams, sublinguals, injections. Ladies really love the pellets, believe it or not, mainly for testosterone and estrogen. Pellets are the tiny little incision right on the side of the glute. We insert the slow release pellets under the skin. Every 3 months, they're re-administered. They work extremely well, but not every lady wants to get the pellets. Again, creams, pills, injections. Another fun fact a lot of people don't know, a lot of ladies don't know, When you think of testosterone, you think of male hormone. When you think of estrogen, you think of female hormone. Well, men and women both make both those hormones, but here's one thing you probably didn't know. As a woman, your dominant hormone is testosterone. Believe it or not, as a woman, you make more testosterone than you do estrogen. The tricky part here is when you look at a blood panel, you see testosterone here, you see estrogen there. There's a reason for that. It's because they're measured in different units. Testosterone is measured in what's called nanograms per deciliter. Estrogen is measured in what's called picograms per milliliter. If you break them down into comparable units, a woman's dominant hormone is actually testosterone. Now, still a fraction of what a guy makes. You make about 1/20th of what a guy makes, but that is your dominant hormone. Well, here's a problem with testosterone for ladies. It's not FDA approved. Why it's not FDA approved, I have no clue. Probably the same reason why there's absolutely no information available to women on menopause. There's not FDA approved. So when it's written off label, which is very safe to do. It's just that you can't go to a pharmacy and buy it. And here's the thing with testosterone. It's a very important hormone. So all these hormones together serve their purpose. Now, I mentioned with an intact uterus being able to take or having to take estrogen and progesterone. For women who have had a hysterectomy, if you do not have an intact uterus, you are allowed to take estrogen alone. There's no harm in that whatsoever. The key is how much do you take? When do you take it? What do you need? This is what the blood panels will detect. Internally at LifeMed, this is what we do. The blood panels are extensive, and whether it be us or any other hormone clinic you go to, you must have a full blood panel done to make certain you're a candidate for hormone replacement therapies, because not every woman is a candidate. Okay, so if you're at risk for stroke, if you've had a heart attack, if you've had blood clots, if you've had cancers, even though we can have a whole nother conversation about estrogen and cancers to show that people say, oh, well, estrogen replacement therapies cause the cancer. There's no science that proves that, but we won't have that conversation. Generally speaking, if you have especially estrogen sensitive cancer, you would not take estrogen. There are some non-hormonal FDA approved estrogen therapies. I think somebody commented actually on one of the posts I put up. I'm not sure if you guys saw that. It's actually called Veoza. So they just FDA just approved that back. I think it was November, December. I wasn't aware of this. Somebody commented on it, but it sounds like they went to try to have a prescription filled and it was costing them like $530 a month, I think, to get this non-hormonal treatment together. But the women without uterus can take estrogen alone. The objective is to restore what your body is now missing, what your body is deficient in. Okay, we use what's called bioidentical hormones. Bioidentical means it matches the molecular dynamic of what you make almost exactly. They come from yams. So this is the thing, anytime you're getting hormone replacement therapies now, it's almost always going to be bioidentical hormone replacement therapies. They originate from yams. And the goal is to get you back to restore your levels to where you were prior to menopause. Because this is what's happening. A lot of people want to know, especially with the hot flash and night sweats, like what causes these hot flashes? Well, here's the thing. Pretty much every cell in your body has receptors that rely on estrogen. And it just so happens there are some in your brain, mainly your hypothalamus, that is very, very sensitive to estrogen. So for your whole reproductive life cycle, from the date of your first period to the date of your last period, your ovaries are sending very consistent estrogen, progesterone. Day one's the first day you bleed. FSH kicks in, follicle stimulating hormone. Estrogen is released. At about day 14, you ovulate. An egg is released. Estrogen drops off, luteinizing hormone kicks in. Progesterone now goes up to prepare the lining of the uterus for pregnancy. At about day 21, your body recognizes you're not pregnant. Progesterone plummets. The lining of your uterus sheds. That's what causes bleeding. From the date of your first period to the date of your last period, that is happening every single month. And if you're lucky enough, it's happening consistently, a 28-day cycle, 29-day cycle. It's happening very, very consistently, like clockwork. And your brain gets very used to that consistency. Well, all of a sudden, as you start to enter into perimenopause, your ovaries are getting ready to be done releasing eggs every month. So now all of a sudden, they start to sputter a little bit. A lot of estrogen, a little bit of estrogen. Some progesterone, no progesterone. Well, these receptors that you've been relying on for 20, 30 years now start to scream, like, what is happening? Why am I not getting this stuff? This is what causes the symptoms. So the whole goal with hormone replacement therapies is to replenish what is now deficient. After you go through menopause, a lot of women think, well, hormone replacement therapies, I should only start prior to, or I should only start afterwards. To make a very, very general blanket statement, a woman who should consider hormone replacement therapies, and these are not the only women who should, because there are other cases, but based on what you read, any big studies you read, they would say 60 years old or younger, less than 10 years postmenopausal. That's when a lot of the very large organizations all agree that as long as you don't have major health conditions, again, at risk for stroke, cardiovascular disease, heart attack, deep vein thrombosis, 60 years old or younger, less than 10 years postmenopausal is what they recommend as the time to start. And when I talk about organizations, I'm talking about very large organizations. The American College of Obstetricians and Gynecologists, the American Association of Clinical Endocrinology, the Endocrine Society, the North American Menopause Society. These are all major organizations that all say hormone replacement therapy started at the proper time should be considered by women. It should be researched. The other bit of information I get that's so false, I hear this all the time, women think that there should only be a short window of time that you take hormone replacement therapies. The least amount possible for the shortest period of time. And that is dangerous too, because there's no science, there's no study that shows a woman should only take the least amount for the shortest period of time. It's all about when you start. It's timing of initiation. And generally speaking, 60 years old or younger, less than 10 years postmenopausal, not at risk for any of those underlying comorbidities. If that's the case and you start on hormone replacement therapies, there's no study that shows that you have to stop in any given period of time. Especially important for women who have gone through and had hysterectomies, because this is where it gets dangerous. The younger you've had hysterectomies, if any ladies on here have had them, hopefully your providers have recommended hormone replacement therapies, because the longer you go without that estrogen protection, the more it wreaks havoc on your heart. These are all things, guys, that every lady needs to know that your doctors don't tell you. Your doctors just are not informing you. And the problem is, if you don't educate yourself on this stuff, you're going to go to your GYN, you're going to listen to what they tell you. And I'm not saying you shouldn't listen to them. I'm not saying that. But what I'm saying is, me personally, I don't believe anybody should allow their providers to make 100% of their decisions for them. I just don't think that's healthy. Maybe it's 90%, maybe it's 95%, whatever it is. There needs to be some form of education that we all get, not just as ladies going through to see your GYN, guys as well. Right? We deal with stuff as well, not nearly to the level that ladies do. And I think this is where my obsession really came from. I'd have guys coming in, oh, Eric, I lost some muscle mass. I got some extra body fat. I don't have much energy. I got some sexual vitality issues. I think I'm low testosterone, right? We pull their blood. We check their blood. Yep, you're low in testosterone. They're a good candidate for it. We start giving them a weekly injection. They're out the door. Have a nice day. See you later. Everybody's happy, right? Ladies come out, and it's this complex puzzle of all these different symptoms and all these different issues and thyroid stuff and elevated hemoglobin A1C and all these other things. It's this huge puzzle. And I just became totally infatuated with trying to figure out that puzzle. And it just so happens the puzzle's not that complex. Okay, with the exception of some of these symptoms, every woman goes through almost the same stuff. How severe it is, maybe it's not as severe. But you all go through menopause. Your body all goes through this craziness. So if we're not out there educating, if we're not out there helping people understand, I have two daughters. My daughters are 19 and 21. They have a little ways to go before they go through menopause, hopefully. Right? But if we can't educate ladies on what to be aware of what to be cautious of what to look for, then we're doing them a disservice. Fortunately, we're just now starting to see, I personally believe, maybe it's because I'm in the middle of all this stuff and because I'm just so overboard about trying to convey this message to as many women as possible. It might just be that I'm looking for it, but I have to say, I do feel like there's been a lot more positive press out there about menopause, a lot more awareness about menopause, and most importantly, about hormone replacement therapies. This is something, again, every woman needs to be educated on it just to know what's available to you, because I've seen way too many ladies come to my office that are struggling. And the issue is, as ladies, what I've experienced, you all put yourself very, 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 very last on that list of priorities. Like, you'll sit down in front and be like, well, the mailman needs something, and the guy at the grocery store. And it's like, okay, you got to start thinking about you too, right? And the ladies who come to me, they're struggling because they're not sleeping. They can't concentrate. They have no sex drive. They have vaginal dryness. Their husbands think they're cheating on them because they don't want to have sex. They're taking care of their parents. They're taking care of their husband's parents. They're taking care of their kids. And it's like, Eric, I have nowhere else to go. Like, somebody please help me. I'll call husbands all the time. And I'll sit down with the ladies first. And I'll be like, hey, is your husband giving you a hard time? Because this almost always happens. And be like, yeah, my husband's giving me a hard time. I'm like, all right, would you mind if I talk to them? You want to have them call me? Almost every time they call me. They're like, hey, Eric, Susan told me to call you about hormones. You're talking to her about hormone replacement therapies. I'm like, yeah, I talked to Susan. So how are you handling stuff? I know Susan's struggling a little bit, but like, how are you handling stuff? And every time they're like, oh, it's tough, it's rough, it's crazy stuff. Like, I don't know what she's going through. And, she's always upset and she's not sleeping and she's snapping at me and getting angry at me. And I'll say, okay, scale of 1 to 10, how frustrated are you with your wife? So 1, you're not frustrated at all. A 10 is you're just insanely frustrated. And almost every single time, the guys be like, I'm an 10. I'm like, okay, you're a 10. I get that. Here's the thing. Your wife on that same scale, she's like 126 right now. So do me a favor. Do yourself a favor. Give me 60 days. Let's have her blood panel pulled. Let's have her sit down with one of our providers. If she's a candidate for hormone therapy, let's talk again in 60 days and see what happens. Like clockwork, they come back out. It's normally the lady who calls me back. Eric, I'm in the office. Can I talk to you? Sure, no problem. They come in, they close the door, they start bawling their eyes out because I saved their marriage, because they're happy again, because they can sleep again, because they're not getting upset all the time. This is what hormone replacement therapies do. Not only does it provide that almost immediate menopausal symptom relief, and when I say immediate, it's about as quick as it can possibly get. I mean, in a matter of a couple months, normally our ladies are feeling better again. Not only does it deprive ladies of that, more importantly, what it deprives ladies of is the long-term health stuff. Bone, brain, heart. These are things that we can prevent this stuff. There are tests that we can run. There are hormone replacement therapies that you can take. I read these studies now and I see these things and I watch everything I read. The new thing now is cognitive behavioral therapy. If you're a woman going through menopause, go through behavioral therapy. Like meditate or something. It's like, really? So you think that, or carry around a battery powered fan and a cup of water to splash yourself in the face when you get hot flashes. Are you serious? Like, that's really your answer to this, right? I mean, this is wild, and it's just straight out dangerous. My whole goal, guys, is to go out and spread the word of this is what women need to know. It's to arm you with information. So again, when somebody says something, when you go to your doctor, you can question them. You can push back on them. You can say, hey, give me some information. And again, at the end of the day, you're going to want to take the advice of your providers. I 100% respect that. But you're doing yourself a disservice if you're not at least exploring and understanding and researching everything that has to deal with hormone replacement therapies. This is something I think what you're going to see here in the next few years. I do believe you're going to see a lot more openness to this. You're going to see a lot more exposure to this. About half of this nation are women. About half of this nation will go through menopause. If there's a way to extend quality of life, why would we not want to do that? I just need you guys to know that I'm out there fighting for you guys. I get all the comments. I got emails even over the last couple of days from ladies like, you're a guy, I'm not watching your webinar. What do you know about hormones? And again, I'm not here to try to even remotely claim that I know what a hot flash feels like, what a night sweat feels like. As guys, we got it pretty easy. Okay, our testosterone, as we age, our testosterone gradually declines. Then all of a sudden we wake up one day and we're like, well, I kind of don't feel that good, right? It's very gradual. Guys, no problem. Ladies, you guys go through all the insanity. It pretty much happens overnight. So for us internally, it's all about bringing to light the things that you might be deficient in. I want to kind of end on this with as far as what we do internally, just to give you an idea. And again, this is how our facility operates. There are obviously other hormone clinics out there. I like to say that we, with us internally, this is really our area of expertise. Again, I told you our medical director's a cardiologist. This all starts with a blood panel that we do. This is advanced biochemical testing. We're checking 80 plus markers. It's hormones, genetics, cardiac particle sizes, metabolic, kidney, liver function, glucose levels, thyroid levels, inflammation markers, vitamins. This is everything A to Z we check. You sit down with one of our providers, they're going to spend an hour with you. So they're going to spend a full 60 minutes reviewing that blood panel. And it's not just the hormones they're going to check. We check all those other markers. I talked about thyroid earlier on. Thyroid is something that lots of ladies struggle with. We're going to check A1C for prediabetes. We're going to check blood glucose. We're going to check all these things. For guys, we're checking PSA, prostate-specific antigen. I should comment, if you have husbands you want to bring out, they're welcome to come out as well. We do the same exact blood panels. But at the conclusion of that blood panel, our providers are going to make recommendations for you. This does not come from me. Again, everything I've talked about here is just education. This is not medical advice. We have tons of very smart people internally that are able to give you the prescriptions if you need them. They're able to recommend a daily multivitamin, an omega-3 for fish oil for heart health, vitamin B12 to help you with energy and metabolism, vitamin D that everyone's deficient in, gut health stuff. These are all things. So at the conclusion of that hour-long appointment, you're going to know exactly where you stand, and you're going to be given information that nobody else gives you. No other doctor gives you this level of blood panel. At that point, you decide how you want to move forward with it. A lot of our female patients would like to start on hormone therapies, or they might like to start another therapy. I talked about the weight loss medications. You know, some of our patients are candidates for that. Not everyone is. I will say for the patients who do start on the weight loss medications, men and women, they're very effective. On average, our patients are losing somewhere in the 10 to 15% range of their total body weight. With that, we normally see pretty significant improvements to lipid panels, cholesterols. You know, this is something I talk about being so obsessed with women's health, which I am. Equally, I'm obsessed with cardiovascular health, heart disease, right? I talked about this is something we all, everybody, every single living, breathing human has these heart things going on that we can almost totally prevent, whether it's diet and exercise or pharmacologically. This panel is designed to go through everything. And the conclusion of it, if you decide, hey, this is great, you start on hormone therapies, or maybe it's something else you start on. We also recommend that we do everything in conjunction with your providers. If you have a PCP, if you have an OBGYN, we don't like anybody to make decisions and keep anybody out in the cold. So we do like for you to talk with your other providers to make sure that everybody's on board for the same stuff. And then from there, we continue to monitor blood. We continue to monitor where you are internally. Are the hormones working? Are they not working? Should we increase it? Should we decrease it? Should we change this? Should we change that? Should you stop it? There's all these factors that go into it. But at the end of the day, it's all about you understanding how important it is to replenish the hormones that you're going to lose when you go through menopause. This is what I'm here for, guys. I'm here to support you. I'm here to fight for you. You're going to see me on a lot of media stuff. I've done a ton of television with my first topic on mental toughness and emotional intelligence. I did a ton of TV over the last 5 years on that topic. Now I'm trying to transition into menopause world, and a lot of the producers are calling me and kind of being like, all right, Eric, like, mental toughness, emotional intelligence. Now you're talking about hormones and menopause. Like, what do we got here? Like, what's going on? So I'm trying to really push into that world. I've done some television interviews. I'm trying to really spread the word even more, because even some people don't understand why someone who does not have a medical education, is not a medical person, who's a guy, you know, what is it, Eric? Like, why, you know, what is it about this? Why are you so passionate about it? And I don't fully know the answer to that question. I think because I just see this as being unfair. And I see this as really being such, I don't want to say an easy fix, because menopause is not an easy fix, but it's so predictable. So from my standpoint, it's like, okay, if I can write this book and get information into the hands of the ladies, you can now pass that along to your husbands, to your friends, to your moms, maybe if you're young enough. You can pass this along to women who need it, because there's absolutely no reason any woman should have to suffer through this process. It's just not fair. It's not required. It's not needed. It's not necessary. So if you have the proper education, you now make a decision of, you know what, maybe I should explore this. And if it works for you, great. I can tell you we have tons of success stories. And this is why I become so obsessed with it. Tons of success stories from ladies who come in on day one hurting pretty bad. A couple months later, lives are back again. I'm here to support you guys. I'm here to fight for you guys. I'm going to be doing all the TV stuff. I'm going to be doing all the podcast stuff. I'm going to be taking on all the people that are telling me I'm crazy because I'm not a medical person. I never had vasomotor symptoms. That's not going to stop me. I'm going to continue to go at it. So please keep an eye on that. Danny, I know you had some comments on there. I saw some popping up. Didn't get a chance to read them, or some questions. You want to try to hit some of those?
Yep, I'll jump through those. First question that was asked of the group is, can you address HRT in fitness?
Yeah, totally. So HRT, just in case anyone doesn't know the acronyms, when you hear HRT, that's hormone replacement therapies. So you hear of HRT, BHRT, bioidentical hormone replacement therapies. You'll hear TRT, testosterone replacement therapies. We recommend, even for our patients, like, okay, if you start on hormone replacement therapies, is that going to help significantly with all your symptoms? Yeah, 100% that's going to help. I would say number two in line, right next to hormone replacement therapies, is most likely going to be exercise. I mean, I don't think this is rocket science to anybody, right? There's study after study that shows the significant long-term positive impacts on cardiovascular health on exercise. As a matter of fact, I just read a study the other day. They took people who were getting zero exercise every week, and they took those people up to 3 hours a week, so about 30 minutes a day. So people who were exercising 0 hours a week to 3 hours per week decreased their risk of cardiovascular disease by about 50% just by exercising. So when we talk about hormone replacement therapies and exercise, they are yin and I mean they go together. That I don't want to say if you do them both together, you're going to get the optimal benefits from it. Just exercise alone without balancing on hormones is going to be really difficult to get the goals that you want to get, to hit those things you want to hit. But 100%, when you mix those two together, when you balance out hormones on top of the exercise piece, obviously the third piece of that pie would be diet. But you put those together, and that's a match made in heaven.
Awesome. All right, next question. You kind of touched on this, but I'll replay because I'll make sure everybody feels like they get the questions. Why does all our weight end up in the middle?
Yes, this is weight redistribution. So what ends up happening with ladies is it's the way your body processes fat. It goes into that mid region. This is referred to as visceral fat. You guys might have heard of visceral fat before. It's visceral adipose tissue. So basically, if you look at fat that surrounds this midsection, the pinchable stuff is referred to as subcutaneous fat. This is for energy. This is good. You need to have subcutaneous fat, or else you wouldn't be able to store energy. The fat on the interior is referred to as visceral fat. Visceral fat surrounds organs, can be very dangerous, and it's a very good indicator for cardiovascular risk. But for women, this is all about a redistribution for how your body processes, and it goes right to that mid region. This is where all the ladies go. And I'm going to tell you again, not saying it's impossible, but it's about as close to being as possible as you can get to get rid of that body, to get rid of that midsection fat when you have hormones that are imbalanced.
Awesome. Next question is, I have factor V. What are some hormone options for blood clotting disorders?
Yeah, so at that point, that gets way more in depth as far as working with a provider. Generally speaking, if you're at risk for blood clotting stuff, hormone replacement therapies would probably not be recommended. But that's a conversation you would have with your provider to discuss that. So you might not be a candidate for all the hormones. You still might be a candidate for testosterone or estrogen. That's something that you would definitely want to talk with one of the providers about. I would not want to give any sort of medical advice on that. But generally speaking, any kind of blood clotting disorders would most likely disqualify you from hormone replacement therapies, unfortunately.
Which is the best healthcare provider to go to for HRT?
Good question. If I'm being biased, I would say us, right? If I'm being biased, I would say us. So there are obviously medical facilities out there. It's our expertise. It's what we do. It's all, I mean, that's the core of what we do. All of our providers, our medical director, again, I said was a cardiologist, 10 nurse practitioners, 2 physician assistants, our 1 additional MD, all go to extensive hormone replacement therapy training. It's out west. It's with a doctor named Neil Rosier. He's the world-renowned expert on hormone replacement therapies. So are we the only place? Absolutely not. We're not the only place. But prescribing the medication is just a portion of the equation. What we really thrive on, Dan, you mentioned this in the beginning, and I'll thank you again for the kind comments. What we really thrive on internally is that customer experience. You know, when you think about wellness, you think about physical wellness, but there's other components to this. There's physical, emotional, spiritual, social, intellectual. These are all components to it. So with us internally, we prescribe the medications. We have very highly trained providers who are very skilled and know how to prescribe the medications. In conjunction with that, we also like to treat our patients and make them feel like, hey, when you're here, you're home. It's a huge family we have. We're up to 5 locations now. We have not lost that small family feel. When you walk in, you become friends with people. You have access to us at all times. You can call me any time of night because my phone's on all the time. I'm a crazy person. Unless Bachelor's on. I'm missing Bachelor tonight, by the way. But that's okay. My daughters will fill me in. So there's other facilities out there. Again, like I said, I think we do it differently just because of that patient experience.
Is there a natural way to regulate hormones outside of HRT or regular Western medicine?
Yes, this gets difficult. So if you have a true hormone imbalance due to perimenopause, menopause, postmenopause, meaning that your ovaries have stopped to produce, or if you've gone through hysterectomies and you had ovaries removed, there's very little, unfortunately, you're going to be able to do to override that hormone imbalance. Are there things you can do that are going to help? Yeah, absolutely. Dieting, exercise. I talked about cognitive behavioral therapy, a battery powered fan, splashing yourself with water in the face. I mean, there are other things you can do, but realistically, without pharmacological interventions, it's going to be very, very difficult to take those hormone imbalances and just modify lifestyle issues to correct it. Now, again, I'll go back to the exercise piece. That I would say is probably one of the most important things in conjunction with the dieting. But again, critically important to point out, if the hormones are going wonky, if the ovaries are sending inconsistent messages, if they're getting ready to putter out and stop producing those hormones, there's really not a whole lot you can do outside of pharmacological solutions that are going to overcome that, unfortunately.
One thing I'll just tack on to that, guys, is that a lot of people think that, well, if I take this stuff or what have you, that it fixes everything and it's a wonder drug, right? Like it's wonderful, right? But there are plenty of people who are out of shape and unhealthy whose hormones are operating just fine, right? It's a holistic approach, right? And so part of the reason why I wanted to bring Eric on here was because of the fact that I do see people, and now especially with the advanced program with the herd, where we can see what you're eating and we can see how often you're going to gym, see how many steps you're getting, and see you still frustrating. Like I've seen plenty of females and men as well come in and you watch them, they're busting their ass, they're sweating, they're working hard, they're watching their diet almost to a point that it's not fun, right? And who wants to live a life that's fucking miserable the whole time? So this is an option for you. So just as you look, if you're considering pursuing this option, make sure you're pursuing it understanding this is that whether you go see Eric or them or not, I say this to guys all the time. It probably applies to guys more so than women, but I'll say it just the same. I would never recommend to a dude to go get testosterone from some dude in the back of the gym that came shipped in for Tijuana, Mexico, right? I would never recommend that ever in a million years, right? Just like I'm not going to recommend you guys doing something with going willy nilly, but like Eric and them knew that I was on TRT. I still got a blood panel, right? I go in tomorrow morning for my blood panel reading. So go and have a medical professional that's going to look at that side of the house, give you an honest answer, and then make a decision based from there. Another question we have is I wonder if I take HRT. I wonder if I can take HRT while I'm taking Synthroid. I think I said that right. I'm a redneck.
Yeah. Yeah, so Synthroid, Levoxyl, these are medications to help with people who are suffering from mainly hypothyroidism, underactive thyroid. And the answer is yes. There are very minimal contraindications with hormone replacement therapies, but absolutely, Synthroid is what's called a T4. So yes, you most certainly can. As a matter of fact, it works really well if you optimize the hormones and also optimize the thyroid. And here's the key with it too: it's all about optimizing. So a lot of times, thyroid panels come back in range, and that term drives me nuts. I can't stand in range. So yes, absolutely, Synthroid, Levoxyl, those T4s to treat hypothyroidism most certainly can be used in conjunction with hormone replacement therapies.
Okay. My birth control pill had too much estrogen as a 43-year-old, was causing high blood pressure. I'm now on something with less estrogen and blood pressure meds. My heart doesn't race as much. Is there truth to all of this? I wonder if I need other testing done.
The short answer would be you most certainly, absolutely, positively do need testing done, without knowing what testing was already done. Hypertension, especially, I mean, again, this is a very underappreciated. I talk about osteoporosis and osteopenia and bone disease being an underappreciated disease. Hypertension, it's the silent killer. And unfortunately, as ladies start to enter into that perimenopause age, you start to see the increased risk for hypertension. And it's almost totally treatable. Again, pharmacologically, nobody likes to take blood pressure medicine, but if you're genetically predisposed to something, that might be the case. Could be the birth control, or it could be a genetic predisposition. I'm 50 years old. I've been taking blood pressure medicine since I was 35. There was nothing I could do. I exercised, I died, I did whatever I possibly could. So the short answer would be blood panel will be done to determine Is it the estrogen? Is it the birth control that you're taking? That's difficult to tell without getting a full blood panel, but it would absolutely be something to explore. Another important thing I wanted to point on too, Danny, just for any of our patients, if you do decide to come out, it is important. Don't change anything. So like if you're considering coming out to us or anywhere else and you're gonna have the blood panels done, what we don't recommend you do is totally skew your whole daily, I was taking blood pressure medicine, I'm gonna stop taking it to get this test. Do not change anything when you come out for your blood panels. It's important to disclose all that information to the provider, and we have an initial consult that we do before you have the blood draw done. You went through that as well, Danny. You have that initial consult, which is a conversation with one of our providers to go over your medical history, medications, predisposition to any other types of ailments. These are all things you talk to with the provider. So when the blood panel's done, they'll take that into account, whatever medications you were taking. But yes, it all absolutely positively starts with the blood panels.
Right. How does HRT interact with birth control, and is HRT covered by health insurance?
The multiple components there. I mean, generally speaking, you would not normally see someone taking birth control and HRT, to make a very generalized statement. I'm not saying you can't, just generally it wouldn't happen. HRT can be covered by insurance internally with us, with LifeMed. We're a concierge wellness center, so we do not accept insurance. The only thing insurance normally covers is the initial blood panel. You would still be susceptible to copays, deductibles. We do have Quest right in-house to pull blood. I'll talk about my locations here in 1 minute. We don't offer anything with insurance. Everything's gonna be concierge. The issue if you go in hormone replacement therapy, if you're using insurance, and I don't sound negative when I say this, but a lot of times, number one, it's very, very difficult to get your doctor to pull the panels to determine that you are a candidate for it. Number two, the dosing, unfortunately, normally they're going to follow that mindset of least amount for the shortest period possible, which is just not good information. But yes, if you have a GYN or someone who pulls your blood and determines you're a candidate, you most certainly could get HRT prescribed by your doctor. You'd want to make sure that it was bioidentical. There's synthetic hormones. I'm not going to say they're horrible. That's not the case, but everything right now shows that the bioidentical hormones are the best to take because it does match that molecular structure of what you make naturally. The last thing I wanted to point on there too, Danny, I saw something pop up on here that you might have been getting ready to hit on it, but we're LifeMed Institute. I think somebody asked the actual question of the name of our company. We're LifeMed Institute. We have 5 different locations. So we're in Timonium, Maryland, Baltimore County. We're in Towson, Maryland. We are in Columbia and Howard County, which is probably closest to a lot of your members there, Danny. Our 4th, then we're also in Rehoboth Beach, Delaware. And then our newest location is in Harford County, up in Bel Air. So we have 5 different locations total. We're up to about 73 employees, I think it is now. Another thing I wanted to point out to everybody on here just before we cut, everybody on the call, if you would like to come out for an IV, we also do IV therapies. I talked about the hormone replacement therapies because that was really the core messaging of this webinar. We do tons of other services. The IVs, I would love everyone who's on here, if you like a complimentary IV, I'd love to invite you to come out to grab one on me. It's a bag of saline. It's a 500 milliliter bag of saline. All your B vitamins, vitamin C, calcium, magnesium, zinc. You sit down for like 45 minutes in a massage chair, rubs your legs, rubs your back, you dehydrate. Everybody knows them as the hangover bags. You don't have to be hungover when you do them. Love to comp all of you. Your first one on me if you like to come out. Bring a girlfriend along if you like to. You can even bring a husband if you want to. I'll comp you guys the first one. Danny, I think you're gonna have all my information up there. Hopefully so. I'd love for you all to have my cell phone number, to have access to me, to text message me, to call me. Social media stuff, I'm on Instagram. Please follow me there. You're going to see me doing a lot of stuff with a lot of TV pushing stuff out there. But I'd welcome all of you to, again, questions, comments. HIPAA comes into play also. I know everybody knows this, but HIPAA is privacy. So anyone who calls me and has a conversation with me about anything, I do not repeat it. So if your husband calls me and asks me a question, I'm going to let him know that I have no idea what he's talking about. Unless you're there and you give me authorization to talk with them. But HIPAA comes into play, and there's nothing too embarrassing to talk about. I recognize I'm not a medical person, but I will tell you about every single conversation you could possibly think of. I've had them with ladies, and I would obviously love to help you. But the locations were all throughout Maryland and the one in Delaware. Just want to hit on that, Danny. I saw that pop up. Sorry.
Awesome, guys. So listen, as we get ready to wrap this up, my thing to all of you, again, I wouldn't recommend anybody that I didn't have complete faith would take care of you guys. I've already recommended a lot of my own, my personal friends and family out to Eric. Um, Check the place out. And I believe everybody, I think the future of fitness is headed to this. I mean, I said this to Eric. I think that in the next 5 to 10 years, there's going to be some merging between institutions like his and various gyms. I think we're going to start moving to a future where your blood panel getting pulled is going to be just common practice because it's going to allow you to see things outside of just how strong I am, what size dress I'm wearing. And I think there's going to become a time where you'll have your blood panel pulled and you'll have an organization like them, and we'll use that to help craft your workout program. That's coming down in the next 10 years. And I'm excited that people are getting to the point where they're open to this because it does make a big difference. I will tell you on the flip side, if you guys are interested in getting a book for your husband, to maybe help start them on there because Eric hasn't wrote a men's book yet. There is another doctor, a gentleman out there by the name Dr. Simpson. His book was actually the book that got me started on looking at HRT, called Honed. It's HONED. It is to help men age past 40. He is a certified badass, special forces ranger, the oldest man ever to go on active duty combat patrols. And he talks about the importance of HRT for men. I have a podcast that I did with Tim. I'm going to have Eric on a podcast here coming up soon, so you'll get more information of this. But guys, at the end of the day, open yourself up, be educated, make the best decision that's going to help you live healthy, and the rest of the time, and able to keep moving head down, horns up. I did see one last question. I think I can even answer this for Eric. Virtual meetings, they're going to need you to come in. I mean, and honestly, that's probably one of the things that makes me have more faith in them than anyone else, because a lot of people will just send you some shit in the mail. Like, they need to see you.
Yeah. So basically, the first appointment we have is what's called an initial consult. That's where you have 30 minutes with one of the providers. That technically can be done remotely, but the wellness diagnostic, which is the hour-long review of blood, that one needs to be in person. And you're right, Dan, hit the nail on the head. That's a meeting that you want to have in person because it's so extensive, because they do such a thorough review to go over that advanced biochemical testing, that comprehensive panel that we pull. So technically speaking, initial consult can be virtual, but the wellness diagnostic, the hour-long review, to meet healthcare guidelines, we have to make certain that that one is done in person.
All right. Hope you guys got something out of the call. By all means, remember, the most important thing is if you learned anything today, share this with someone you love, help them out. It also make sure that you learned the lesson. Remember, first step to the storm should be on. Keep living head down, horns up. Salute, fam.
Appreciate you guys.